I really want to help you. I really want to help you. Hi, Dad.
Testing 1, 2. Go play. Do not bounce the ball in the building. Go outside and play. Testing 1, 2. Welcome. Test 1, 2. Welcome. Testing 1, 2.
PowerPoints on here. We started getting sponsors because we can't afford all the parking. And so there's a woman from a state law that's going to do, like, she sent me her PowerPoint last night, so it should be the last two on here. How are you doing?
I feel much better now. It was freezing.
Yeah. I could probably try to do that, Mark, but I would probably look pretty ridiculous. Probably fall flat.
I think I had to use that.
Yeah. We went over to that brain ride one at the URA Institute. Should be the last two if you want to modify it. Yep, that one and the next one. Yep. Yeah, those are old ones. Now they're charging over lifelong to not only have papers now on Saturdays, which, you know, I did, now we yeah.
Really, if you promise to clean up yourself? How about on this side? It's not gonna have people working for it.
Yeah.
Right?
Yeah, this is like Saturday.
Does the speaker,
Yes.
the main speaker, does the speaker at the podium or shoot?
When I saw that email from them, I thought it looked like you had gotten it.
I did. I thought so. I was like, I was looking.
You know what you have to say, and I never really paid attention to the bar. Yes. He came to me and I said, absolutely, I'm sure that's what he did with it too. That was really nice. Yeah. Yeah. That's really nice. Well, no, you're a perfect candidate. I was happy to do it because, oh no, I was happy, I'm glad you asked. I don't really pay attention too much to those things, you know, so.
Testing, 1, 2. Welcome. Testing, 1, 2. Testing, 1, 2. Welcome. Testing, 1, 2. Welcome. Testing, 1, 2. Testing, 1, 2. Welcome. Testing, 1, 2. Testing, 1, 2. Testing, 1, 2. Testing, 1, 2. Test, 1, 2.
Yeah, it does. It does. Yeah. So. I know. I always say. Yeah.
Testing, 1, 2. Testing, 1, 2. Testing. Testing, 1, 2. Testing, 1, 2. Welcome. Testing, 1, 2. Testing, 1, 2. Testing, 1, 2. Testing, 1, 2. Test, 1, 2. Testing 1 2. Test 1 2. Welcome. Testing 1 2. Testing 1 2. Welcome. Test 1 2. Welcome. Testing 1 2. Welcome. Test 1 2. Test 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 test. Testing 1 2. Testing 1 2. Testing 1 2. Welcome. Testing 1 2. Test 1 2. Testing 1 2. Testing 1 2. Test 1 2. Test 1 2. Testing 1 2. Welcome. Test 1 2. Testing 1 2. Test 1 2. Testing 1 2. Welcome. Test 1 2. Test 1 2. Testing 1 2. Test. You been a guest speaker?
Oh, no,
You been a guest speaker?
I'm sorry. I was trying to read the slide all the way from here and listening to you. That's all. I'm sorry.
Okay. Testing 1 2.
Sounds good to me.
Testing 1 2. Test. Testing 1 2. Welcome. Test. Test 1 2. Testing 1 2. Testing 1 2. Test 1 2. Testing 1 2. Testing 1 2. Testing 1 2. Thank you. Test 1 2. Testing 1 2. Testing 1 2. Testing 1 2. Testing 1 2. Welcome. 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 Testing 1 2. Testing 1 2. Testing 1 2. Welcome. Testing 1 2. Welcome.
How was it up north?
Testing 1 2. Welcome. Testing 1 2. Welcome. Testing 1 2. Testing 1 2. Welcome. Testing 1 2. Welcome. Testing 1 2. Welcome. 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 Testing 1 2.
I like the sunshine there.
Would you like anything to eat? They had, you know, that brain thing. Chips,
Chips?
chocolate chip cookies.
Get some for the boys.
No, take this.
I have nachos. Anybody want nachos?
He has three, the cutest little guys.
Oh,
So
yeah.
you need three, you can't go home with two.
All right, thank you.
You wanna give him the chips?
Oh, sure.
Now we need,
Nacho-
Hopefully like the
Doritos
Doritos.
nachos.
There you go.
okay?
That's perfect.
yeah.
Thank you. I'm on the basketball court right now.
Oh, there you go. They probably won't eat the apple, but you can eat the apple.
Testing 1 2. Testing 1 2. Testing 1 2. Testing 1 2. Welcome. Testing 1 2. Welcome. Testing 1 2. Welcome. Testing 1, 2. Welcome. Testing 1, 2. Testing 1, 2. Welcome. Testing 1, 2. Test 1, 2. Testing 1, 2. Testing 1, 2. Testing 1, 2. Testing 1, 2. Welcome. Testing 1, 2. Testing 1, 2.
You need to know exactly how to spell it. Alright, so who wants to go to the parking lot and stand in the sun?
Testing 1, 2. Testing 1, 2. Welcome.
Oh, just me? Okay. I do it all the time. Pretty much what I do. Kelly was like last time when she came up, she was like, what is the grade of these things? And I was like, part of it is I just like to stay out of the way of the room. I wasn't moving. Stuff had to stand by the garage. That one's not if I get bit by mosquitoes. I have a line with you are, and that's awkward. Yeah, everyone's always like, oh, the one thing was, I'm like, I don't know. I'm like, I don't know what you're talking about. Okay. Does anyone want, did you get a copy of the
Okay, yeah. You can register, I mean, you can check in if you want.
Oh, okay. I didn't know that.
Is it again or?
Okay.
Alright. I'm gonna go now. Perfect.
Oh, here I am.
Testing 1, 2. Testing 1, 2.
Alright. I'm off to the parking lot.
Testing 1, 2.
Thank you.
Okay. You don't have anything? Oh, I have. Oh, I'm sorry. You typically have pens that are coming off. you go to? That's funny. That was good. It was just always good to hear what researchers are doing. Yeah, it could have been. I know. It could have been 2 hours. Yeah. And
How you doing?
Good.
Too bad.
Sponsor today. I don't know, we were able to get an attorney in the law firm to do a couple minutes of it, so we'll have presentations. Okay. She sent me her PowerPoint last night, so it's loaded. I just wanted to make sure you knew.
I just wanted to jot down that name because it's definitely, I have to be honest, when I came into Ladies Lab, I was really focused on, what else to do, like the problems that are going on right now.
This is her mom.
Absolutely. All right, awesome. Well, I look forward to this, and I'll definitely shoot you over an email if we can figure out maybe a time we can actually discuss the research that we're going on. All right, thank you.
Hi, Jim.
Hey, Jeff, how
How
are
you
you?
doing? What's going on? Come here. We have to come up with a grand master from your schedule. That's the answer to this. Holidays, semi-holidays, Christian holidays, Jewish holidays. That's good to hear.
Yeah.
I heard that thing earlier with Gavin Rambach from Scripps. He talked about the genetics about this.
Oh, yeah?
I don't think he thought about it. No, he actually made it fairly simple. But it seems it's still in the future. It's always in the future, but somewhere down the line they're going to come up with something that will help.
Good. That'll be fun.
Yeah. You gotta
All right.
take care of this.
See you later.
enough to sponsor 4 of our events. So she has some giveaways there, and she has a presentation. These may be helpful if you have the PowerPoint, because the print is very small in the handout. So these are magnifiers. So if you'd like one of these, I can pass that over to you. And thank you so much, Ann, for coming. We appreciate it.
Can everybody hear me? Do I need a microphone? Oh, okay, all right, so I will. So, do you want me to use this one or either one? Whatever you go back. I'll just use this. Okay. So my name is Anne Desormier. Turn it on, is that what you just said?
On top.
I make you come down here and then, I answer my own question. So my name is Anne Desormier Cartwright, and I'm a practicing lawyer for about 30 years, actually 34 years, all in Florida. And I tell you that I'm also a trial lawyer, so that if there are disputes, I can also help with disputes for estate planning. I am going to talk to you in general about what special needs planning is and what my firm can help you do. I will, in general, talk about 2 things, 2 issues. So, a child with special needs, when they turn 18, is considered an adult by law. They can make their own contracts, they have access to their health information, same as a non-special needs person. So what ends up happening is they can go out in the world, buy a car, do lots of things with their thoughts and what they think are their assets, and then they come to find out, or you find out, that they've entered into this relationship or this arrangement that is not good for them. One way to be able to stop that is you become their guardian advocate, and you can actually apply for guardian advocacy 6 months before the person turns 18. It's not a difficult process. My firm handles it all the time. Many elder law attorneys do this work. Not all estate planning attorneys do this kind of work. But a guardian advocate is someone who stands by the side of the person with the special needs and helps them navigate the legal issues, making sure that contracts are properly signed. The guardian advocate signs it. The way it works in Palm Beach County, not all counties do this, is once that guardian advocate is appointed, there are no other reports that need to be filed with the court. So what's fantastic about that is you're appointed the guardian advocate. You don't have to report to the court the assets that the incapacitated person receives. You just act in their best interest. If in fact the ward wants to restore some of the rights because they feel that their situation has become available to them where they can have some of their own rights restored, then an attorney would get involved again. Otherwise, the guardian advocate stands in the shoes with the ward, and then it goes on until they pass, until the ward passes. The other issue I want to talk with you about is protecting that special needs person when it comes to them inheriting assets, whether it's from you because they're your child, or it's from a grandparent that forgets because they're in New York or New Hampshire or Michigan, and they go, oh, I just have my whole estate plan, and then if my child doesn't survive me, it's going to go to my grandchildren. Well, that's a great plan, except if that grandchild is a special needs person. And the reason why it's important to understand this, in all of my documents, I have a contingent special needs trust that I put in place. And it's contingent because I don't know. Special needs could mean today it's a child that's under the age of 18 and has some capacity issues, or it could mean someone that was in a car accident 20 years down the road and they're a special needs person. So my documents always have contingent special needs planning. So that and the purpose of the special needs planning is twofold. First, there is the ability of that special needs person, if they're receiving government benefits, to continue receiving those government benefits like SSI. So SSI is a needs-based program, which means limited income, limited assets. And if they inherit their assets, which is supposed to be under $2,000 a month, all of a sudden catapult to something very high. And when they catapult to something high, they lose their SSI benefits. It's income. Not as big a deal as losing Medicaid, because Medicaid is going to provide their medical services. And trying to get medical insurance for somebody with special needs is going to cost a lot more than just simply going to an attorney to make sure that that special needs child inheritance is received through a special needs trust. That means that special needs recipient cannot demand, they have no control over this trust, they cannot demand that they receive any money or income from that, and a trustee has to be, I'll say specially trained. It doesn't take that big of a deal to understand that if someone's on SSI, the trust should not pay for food, rent, and electric. Those are the three basic shelter items that the government has said a person cannot live without. A person can live without a phone, not in this world, but that's what the government says. And what you end up seeing is you end up seeing a trust that basically says the whole purpose of this trust is to preserve these assets so that, and the trustee is not to pay for these items which would take away from the Social Security income. Because once all you need is $1 of Social Security income and you get Medicaid in the state of Florida. So if you then go to zero, your Medicaid could go away. So that's why it's important to understand how these assets are supposed to be used. So if there's many ways to set up a special needs trust. You can do it through an estate plan where it's a contingent special needs trust, assuming that child outlives you. Or you could have a third-party special needs trust where it's standalone. Any family member then can contribute to it. So it can start off with $10, and by the time that child needs those dollars, many family members have contributed to it. And it's a great tool for having that ability to preserve the assets and have dollars available for that special needs child as they age and their needs increase. So we do many of these. It doesn't matter where the grandparent lives. What matters is where the child lives, because I'm licensed in Florida, and that's all. So that's all I have for you. But I thought it would be a nice way to introduce what I can do to help you understand things and to help you know what you might be facing. So, great, thank you. Okay.
Agrees to do this presentation. This is one of our deliverables, and we sent this out widely to the nurses, several medical associations, health departments, doctors, and so forth. So I greatly appreciate all of you here for the presentation, and we'll do our best to make sure it's not on a holiday next year. So thank you very much for coming.
I'm more impaired than the last person. There it is. Okay, there we go. Hi! Wake up! All right, we're going to make this as interactive as you want it to be. I'm a developmental behavioral pediatrician,
kind of the sole one in private practice. There's a few of us, I guess, in the Tri-County area, but not many. So we are subspecialists of the field of pediatrics, and my practice is predominantly children with ADHD, anxiety disorders, ASD, learning disabilities, and so forth. We overlap a lot with child psychiatry and child neurology, but we are a distinct field. So how many of you are professionals here? Like everybody, except for a few. So a lot of what I'm going to talk about today may be things you already know, so some of it is by way of review, and I certainly welcome questions as we go along. No question is too small. So we're going to do a bit of an overview, and then I'm going to talk about the real world of private practice, where I am every day, and some of the challenges we face in trying to get families the services they need. But feel free to interrupt as we go along. So most of you know about the terminology change that happened in October of 2015, where we no longer use the term autism, PDD, NOS, Asperger's. With the publication of the DSM-5, all of that is now gone, and autism, PDD, NOS, and Asperger's are now part of the autism spectrum. And actually, surprisingly, some people still don't know this change exists, and some surprising things still happen in the community. But now all of that is subsumed under ASD. And people initially there was a lot of debate when the new guidelines came out, and people were very fearful. Oh my God, individuals with Asperger's are going to lose their diagnosis and they're not going to meet criteria anymore. None of that really happened. Anyone who met criteria prior to October 2015 and was appropriately and rigorously diagnosed would still fit criteria after the change in terminology. So when we talk about ASD, we talk about 3 levels. It's level 1, 2, or 3, which really correlates with mild, moderate, and severe. And severity levels are based on the amount of support an individual needs. So those criteria are clearly spelled out in the DSM-5, but we don't use the term mild, moderate, or severe. We use 1, 2, and 3. It's also important and necessary to specify when a diagnosis is made whether or not that individual has any other syndrome or medical condition associated with ASD. As I mentioned, all prior diagnosed PDD should still meet criteria. There are some people who really miss Asperger's as a term, and there was a lot of familiarity and a lot of identity associated with that term. And a lot of people do still use it. I feel kind of mixed on it myself, but I just thought it was important to mention. And as everyone here knows, ASD, autism spectrum disorders, are neurobiological disorders. They are noted by the social and communication deficits and the restricted and repetitive behaviors and interests. Individuals on the spectrum present with a lot of behaviors and behavioral challenges, but it's not a primary behavioral disorder. Some of the improvements that occurred with DSM-5, one is the inclusion of sensory challenges and difficulties. Surprisingly, everybody knew there were sensory challenges, but it wasn't explicitly part of the diagnostic criteria before DSM-5. There's also an explicit statement for those of you that are nerdy like me and actually read the DSM word for word. There's actually a statement about how compensatory mechanisms can mask a diagnosis, because how many of you here have seen late diagnoses? I mean, we were talking about that earlier before the last lecture. I've seen kids at 15. I've seen adults, come in as their children are diagnosed, getting diagnosed. So we have better verbiage now to explain that and to justify a late diagnosis. And now, of course, comorbidities can legitimately be given as diagnoses. So everybody knew kids on the spectrum who also had ADHD and generalized anxiety disorder, depression, and I left off OCD there, but those are the common ones that we see quite frequently. And comorbidities can occur up to 70%, even greater percentage of the time with ASD. A welcome change was the end of, I think, PDD, NOS for sure, which for years people would come in and say, my child does not have autism, they have PDD. My child does not have autism, they have Asperger's. So it sort of, on the positive side of losing Asperger's, we've sort of lost that idea that different elements of the spectrum were not on the spectrum. Now it's all just seen as part of the spectrum. And to the next point, a greater appreciation of the heterogeneity of ASD. And reducing some of the stigma. So it was really a thing. I mean, parents would say, well, no, it's not autism, it's PDD. But now we have sort of one language to talk about all of these things. And the big change in 4 and 5 was, of course, the blending of the communication and language deficits with the social. So it's considered a social and communication deficit, and then the restricted and repetitive behaviors and interests. So it's sort of a Venn diagram of 2 versus 3. So prevalence, the numbers are high. They seem to be leveling a little bit. The last big study that came out from the CDC that said it was 1 in 68 is kind of holding its own. But if you look at trends over time, it's pretty alarming. So if you look back in the 1980s when it was 1 in 10,000, then in the 90s it went to 1 in 2,500, then in 2012 to 1 in 88, and now we talk about 1 in 68. They are still much more common in boys. The incidence is about 5 times more common in boys than in girls, 1 in 42 amongst boys against 1 in 89 for girls. Autism spectrum disorders do occur in all racial, ethnic, and socioeconomic groups. And the worldwide prevalence is about 1%. There was a 2011 study, and I don't know if anybody here knows of a follow-up to that study. I'd love to hear about it, but out of South Korea in 2011. It made a big splash when it came out because it was showing the highest prevalence of any industrialized nation of autism spectrum disorders. And at that time, we didn't have the new terminology, so it was autism. And I don't know that there's been a follow-up to that study. Still, we have different concerns and complications with special populations. Amongst different racial minorities, ASD awareness and access to services is increasing, but still overall prevalence is lower than in Caucasian children. Certainly there are cultural biases within certain racial groups, so sometimes some over-identify, some under-identify symptoms. I see that in my private practice all the time. I don't know about some of you, if you see that as well, but and girls too are a special group. Girls are still missed a lot, especially those very chatty, highly social, but inappropriately social girls that people don't identify as being on the spectrum. And then, of course, there are sometimes very complicated kids who have either medical complications or other developmental disabilities, and then also really do fit on the spectrum as well. Those kids are often missed because their ASD-related issues are almost dwarfed by everything else. But yet those kids still need to be met. So that's a very difficult population to treat. And there is no biological reason for autism prevalence to differ across different racial and ethnic groups. A lot of it has to do with cultural, social, economic, political reasons. Okay, so if I ruled the world, I don't, but if I did, I'd have a multidisciplinary team. It would be covered by insurance, or it would be free, and I'd have a speech therapist and an OT and a PT and maybe an educator, and there'd be a medical doctor, and it would be amazing, but that's not the real world, right? Unfortunately, in the real world, it's a lot more complicated, and we'll talk about some of the liabilities of that for families, but these are some of the elements that have to be part of really a good and thorough diagnostic assessment. So obviously, comprehensive developmental, psychosocial, family, medical, surgical, behavioral history, that's the baseline. That's the medical provider's job, and that's what I do all the time. Getting parent and caregiver interviews and standardized ratings, also part of my job and done all the time. Teacher interview, observation, rating scales are invaluable. That's something we make a really strong effort to get in my office. Some clinicians neglect that step, but we try to make it as easy for teachers as possible because it's invaluable what they can contribute. Formal assessment of adaptive behavior and developmental skills needs to be done by someone. academic and cognitive assessment of some sort. And I'm going to get into a little more of this later, but sometimes you actually will need someone trained in those types of assessments to be part of the team, or at least contribute that assessment to the team. An autism-specific assessment, and then, of course, assessing for comorbidities. We live in the real world, so I always say you do the best you can. If a kid really needs help and needs a diagnosis, you do what you can to make that diagnosis versus saying, we can't because we don't have all these elements in place. So in private practice, interestingly, in the pediatric world, every pediatrician is supposed to be doing an autism-specific screening at 18 and 24 months. Everybody. Some do, some don't, but that's the recommendation. That's in your general pediatrician's office. And then that pediatrician should be referring that child out for a diagnostic assessment to a specialist if they're failing one of the screening tools or if there's a high area of concern. The specialist who can make that diagnosis could be a developmental behavioral pediatrician such as myself, or a neurologist. Sometimes, and I put psych because sometimes it's a psychiatrist, but sometimes it's also a psychologist. So any of those people can make the diagnosis. This is not talking about the educational world, because there are people that can make educational diagnoses of ASD too, but I'm just going to talk about the medical model. So part of the workup for any physician is, of course, first to review all prior testing. So a typical patient who comes to me might have been seen by early steps, maybe child find, they might have school-based assessments, they might have therapy evaluations, subspecialist reports, laboratory exams, all that stuff I encourage the families to bring to me, and I'm sure other clinicians do the same, because all of that provides necessary background, and some of that supplies us with testing that we may need to validate a diagnosis for insurance purposes, and I'm going to get into that a little more later. The common elements, I mean, this is basic medical stuff we do. We always get the history, direct observation, direct testing, the standardized ratings, vision and hearing screening, and a medical exam for any child who we're trying to rule in or rule out autism. Laboratory assessments are going to vary. There is no one specific laboratory workup for a kid on the spectrum. General pediatricians generally are screening for lead. I mentioned, if some of you were in the earlier talk with the guy from Scripps about genetic testing, CMA is a chromosomal microarray, and that is part of the recommended screening assessment genetically for kids when you're ruling in or out autism. Some of that, whether or not you get that testing, depends upon insurance coverage because it's a very, very expensive exam. Other medical studies are going to be individualized based on the needs of the child. So thyroid or basic metabolic testing, ruling out celiac disease, and so forth. An MRI and an EEG are optional. Those are not part of the standard diagnostic assessment. They may be indicated for various reasons. And then, of course, an assessment of comorbidities. I want to mention something really important right now that's happening as a trend, which is insurance companies are fighting back really hard. So last year was bad, 2018 is worse. And insurance companies are requiring more and more excessive, ridiculous documentation that's autism spectrum disorder specific. So it's discrimination almost against, someone who's trying to get someone with ASD services. For ADHD, I don't need to do all of this ridiculous background testing that they're requiring for ASD. So they're making it harder and harder for families to get treatment, and it's really frustrating. Some of them are requiring a standardized cognitive assessment that an MD would never administer. I do more than neurologists. Neurologists don't even use an autism-specific screener. They look at a kid, they get a history, and they basically make a call. They do a DSM checklist in their head, and they're making a call. Now you have to administer an autism-specific scale of some sort, an adaptive behavioral scale, a language scale, a cognitive scale, and then a medical exam. Now that's 5 elements, and I have a practice where I have the luxury of spending 90 minutes with a patient. Imagine your typical traditional medical model where they're spending maybe 30 or 45 or maybe 60. So it's gotten ridiculous because now families have to jump through hoops and have to spend additional funds to get additional testing, and it's really, really frustrating. We're going to work on that with CARD. We're going to find a way. We're going to find a workaround for that. But that's a new trend this year, and especially Blue Cross Blue Shield of Florida has been horrific in this regard. So everybody here knows what the ADOS is. Everybody's familiar with the ADOS. It's the Autism Diagnostic Observation Schedule. It's really considered the gold standard assessment tool. Not a lot of physicians are trained on it. I happen to be trained on it, but then again, it's not always practical for me to administer in a clinical setting. But I do use the ADOS toddler module quite frequently because it can be done in a shorter amount of time. And a lot of the times the kids who are coming in that are young, that are tricky, the ADOS can be helpful. There are some other ratings I mentioned there too. The social responsiveness scale, some of us were discussing that earlier, as a great tool, but guess what? Insurance doesn't accept it at all, 0. They will take the SCQ, which is a screener, over the SRS, which is a diagnostic tool. It makes no sense. I had an insurance company, it was Blue Cross actually, they required an MChat. That's a screening tool, and they wouldn't accept an SRS. So it's become a game, but there's a lot of tools out there. I've listed some of them here, and I have more listed on this slide here, just to give you an idea of, this lays out all those areas I was mentioning where you have to have autism specific. You need to have, some require even something academic if a child's older, something cognitive, a communication scale, an adaptive behavior scale, and then the other scales are things that I use on a regular basis in terms of teasing out certain comorbidities. And the underlines just represent things that I do, that I'm trained to do, and I can accomplish in my office. They're not preference or anything like that. So any questions so far? So what are some of the pitfalls of assessment? Well, when I have a child and a family in my office for 90 minutes, I'm not seeing them in the natural setting. And I've had kids sometimes that are tricky. The parents are telling me all of these things that really sound like ASD, and I'm not seeing it. It's not there in front of me. Maybe some of the ratings look like ASD and some of the other observations that they're giving me, but it would be so helpful to have an observation in the natural setting. And sometimes we're able to do that. Sometimes we'll get either hire somebody to go out into the field to observe, or sometimes get enough of a good description from a teacher or someone else in the natural setting that it can help fill in the blanks for things that we don't get to see in the clinical setting. There are some parents, I had a case on Thursday. Any clinician in this room would have made the diagnosis in the checkout line at Publix. It was that obvious. It was so obvious. Child Find did not make the diagnosis. Early Steps did not make the diagnosis. The kid is in an ESE program in a local public school, and the parents were beyond frustrated with that, but they underrate. Like everything we did, I'm like, you're not describing it correctly. The reason your child is not getting diagnosed is because they kept sort of not describing things in the way they were actually occurring. So sometimes that can lead to underdiagnosis. And then I have kids, the opposite occurs sometimes where they come in and they want that ASD diagnosis because they want services. And if that kid is not meeting criteria or I don't feel like it's really legitimate, I will not make that diagnosis. It's not right? It's not ethical, it's not fair. But so it happens on both ends, and I'm sure a lot of you here see it as well. Another factor is that kids have good days and bad days. Sometimes a kid is really on and they're having a great day and we're not seeing things, yet the sum total of observations of their behavior really do add up to someone being on the spectrum. And then certain times, especially, it gets tricky with the really, really high functioning kids where it's the social and behavioral pressures that elicit these things that look more spectrum-like. ASD and ADHD, everybody knew before the DSM-5 came out that they were commonly co-occurring. And I've read some studies showing up to as high as 80% of individuals with ASD also meet criteria for ADHD. They are super common. They really run together. And there are shared genetic pathways. As the earlier presenter alluded to, there's a lot of stuff with all of these neurodevelopmental disorders that overlap genetically. Very interestingly, there have been a bunch of studies coming out showing that Early signs of ADHD in the very young children can overlap a lot with ASD. And in fact, that kid I was mentioning earlier who was so obvious to me, they thought it was just ADHD. And he clearly has both. But sometimes people, you know, the ADHD can mask or sometimes just make people see it in one stream versus seeing the other elements of the diagnosis. There are EEG and MRI studies showing that the default mode network in both individuals with ASD and ADHD, that there's a lot of overlap. So there's a lot of commonality, both genetically and neurobiologically. There are certain changes in cortical maturation that we see in both conditions, and obviously the deficits in executive function, planning, organizing, time management, those are integral to both ASD and ADHD. So they're definitely on a shared spectrum of developmental delay and alteration with risk factors, these risk genes, certain environmental factors may play a role in both conditions. I'm going to jump a little bit to some of, this is stuff I'm sure all of you know. What do we consider the effective treatments for autism spectrum disorders? It's always worth just repeating because sometimes people really go off on different tangents. But ABA therapy, I think, still has the strongest body of evidence, as most of you here know. The Early Start Denver model is also a really excellent model, especially in young children. Are any of you familiar with it? Some of you? Not like a lot. I think that's geographical. On the West Coast, they're really familiar with it because you know what? Insurance pays for it on the West Coast. So in the state of Washington, Oregon, California, and parts of the West, it obviously originated in Colorado, they're getting equal payment for ESDM, whereas in Florida, insurances I don't think are covering it, whereas they will cover ABA. Okay. Speech, obviously speech therapy, occupational and physical therapy based on deficits. Not everybody needs PT, not everybody needs OT. Almost everybody needs speech, but those therapies certainly are pick and choose depending on the child's needs. The social skills training models, CARD has done several rounds of the peers model out of UCLA, which is wonderful. And a lot of people use the Michelle Garcia Winter curriculum, that's a great website if any of you are not familiar with it. It's socialthinking.com. She has wonderful materials. Structured educational interventions, which are well-designed and staffed, good ESE classrooms with visual schedules, PECs and other positive behavioral supports and so forth. Targeted treatment of comorbidities can really make a significant difference in outcome. I've seen a lot of kids, when we get, for example, their ADHD under control, can get into the mainstream, can get out of a self-contained classroom and into the mainstream. Anxiety disorders, OCD, et cetera. Not to forget prenatal folic acid. Study after study shows that's very important in prevention of autism spectrum disorders. Stress reduction, I think it's always important to mention because it's stressful. So it's stressful to the individual, it's stressful to the family and the whole, all of the caregivers involved with a child on the autism spectrum. Medication, I'm going to get into in some later slides, but you know, not everybody on the spectrum needs medication. There is no autism spectrum medication. We have medications we use to treat comorbidities and to treat some of the symptoms associated, but we don't have anything targeted yet. Leisure activities are really important because I see kids and their only hobby is a screen. That's it. And that's really a problem. That doesn't do anything to help with their social skills, their language skills. And I'm big on trying to help families not waste time, resources. Obviously, there's individual choice and preference, but when you're driving an hour and a half for a therapy that's costing you, at the end of the year, $20,000, and there's really very little research to support it, it behooves a parent at least to be aware of, you know, what real evidence-based treatment is. Yes? Well, that's been known for some time, so I forget the dose. I think it's 400 micrograms prenatally. That's neural tube. It is, but there have also been some studies recently showing with ASD as well. I can't cite them, but they're out there. Medications in ASD. So as I was mentioning, we use them for behavioral, cognitive, social, emotional problems, not the core deficits. There is nothing for core deficits. And every single medication used in ASD, other than the 2 FDA approved, just treat coexisting conditions and different target symptoms and behaviors. So when a family comes in and like, I want my kids on medication, we're not talking about, well, what's the diagnosis? We're talking about what are the target symptoms. They're hyper, or they're impulsive, or they're anxious, or they're obsessive. So these are the things that drive medication management more than pure diagnoses. Antipsychotics are used as well, and those are mostly the second generation, in particular risperidone and aripiprazole, which we'll talk about in more detail in a minute. Those are the only 2, that's it, only 2 medications with an FDA approval for ASD. All the stimulant and non-stimulant medications which we use for ADHD are used if there's coexisting ADHD. The selective serotonin reuptake inhibitors and the selective, the serotonin and norepinephrine reuptake inhibitors are used quite frequently as well, mostly to treat anxiety, depression, and co-occurring OCD. Mood stabilizers are tried, anti-epileptics at times, rarely benzodiazepines, but I've seen it. I don't personally use them. And then there's a lot of off-label use. And I don't entertain that because I tend to be an evidence-based practitioner, but I've seen kids on every single med mentioned there, including oxytocin nasal spray by compounding pharmacies, which has absolutely no indication at all. There's research, and people are impatient, and I get why people try it, but there's risks with everything. So the 2 FDA approved are risperidone and aripiprazole, and the latest study, one of the bigger studies that was in the Journal of the American Academy of Child and Adolescent Psychiatry, showed that 1 in 6 individuals diagnosed with ASD, 1 in 10 of those with ASD and intellectual disability are on these medications. The recommendations are never to put children on these first. So when they first got the indication, there was sort of a rush, like this is the autism med, just prescribe it. Insurance will pay for it and it will help. And there's been a pullback since that now, and people are a lot more cautious. And psychosocial interventions are always considered first line, but these medications have a lot of side effects and need to be monitored very, very closely. The FDA approval is actually listed to treat irritability, but in addition, they can help with aggression, hyperactivity, defiance, and stereotype behaviors. Don't get me wrong, there are cases where these medications are lifesavers, and these medications can keep a child in a home, at home, in the community, out of more serious, needing more serious psychiatric hospitalization, but they need to be used carefully. The biggest side effect is weight gain is number 1. Some get sedation, extrapyramidal symptoms, akathisia, tardive dyskinesia is a risk, and that's a really serious issue. I've had the good fortune never to see it, but it can happen. And of course, prolactin elevation. All of the atypical antipsychotics that are listed under that next point have been tried in somebody, but they don't have the indication, but they are sometimes used. There was, as I was mentioning before, the overall rates of antipsychotic use are declining, especially in really young kids. The formal approval, though, is ages 6 to 17. So sometimes they're used in younger kids, but it doesn't have the FDA approval. And there are times where it's a pragmatic issue. You have a wild, crazy, running around kid, aggressive, irritable. There's no ABA therapist, there's no therapy, there's no support system. Sometimes it's compassionate use even just to try the medication. At some point, over 50% of children with ASD will try a medication that's used for ADHD. Response varies. It can vary with age, coexisting problems, and then, of course, the unique psychopharmacological effects in that individual. The younger the child, the more side effects, and that's true for children who just have ADHD without ASD as well. Many of the studies have shown that the amphetamines have a much more likelihood to exacerbate anxiety than the methylphenidates, especially in the ASD population. Also, we see that lower doses are more effective. So sometimes we start on really, really tiny doses and progress up much more slowly. That's true for the ADHD medications as well as the SSRIs in the ASD population. With the stimulants, so the methylphenidates, that's Ritalin and its cousins, and the amphetamines, Adderall and its cousins, the most difficult side effects are related to sleep, which some of these kids already have problems with sleep onset and insomnia to begin with, decreased appetite, increased levels of anxiety that I mentioned. And some kids get this hyper-focus effect where they stim more on preferred objects and they just get more self-involved. And of course, rebound, where when the medication wears off, kids are a little more hyperactive. That's a problem with all the medications. There's another family of medications called the non-stimulants. Some of you may know them by the term guanfacine ER, which is Intuniv, or clonidine ER, which is Capvey. These medications are really interesting, and there isn't a lot of evidence-based research yet, particularly in autism. They are FDA approved for ADHD in monotherapy, that's single-use or combined therapy. And I'm seeing a lot of good things with kids on the spectrum in these medications. Side effect profile is not as challenging as the others, but the common side effects are constipation, fatigue, weight gain, and moodiness. That also includes that group, the non-stimulants, Strattera would be in that group as well. So just in summary with the meds, it's pretty obvious, but worth stating that not every child or individual with ASD is going to benefit from medication. A lot of parents have that preconceived idea. A large percentage, very large percentage of individuals with ASD will trial medication, psychotropic medication at some point in their lives. It is never the first-line treatment. Medication management, as I mentioned, it's driven more by treating symptoms, target symptoms, than a disorder. We try to avoid polypharmacy whenever possible. That's a really positive trend I've seen where initially, I'm going to say, because I've been doing this a long time, 15 years ago, I would get kids and they were on Abilify and Risperdal and fluoxetine and Ritalin, and I'm like, everything on the book, that I think is reduced. And I think that's improved since guidelines have improved, medication guidelines, data has improved, and we're just seeing a lot less of that than we used to. The published medical evidence of good quality still is limited, but when people who are academics who study the strength of evidence, if you're a researcher, for the atypicals, it's still considered high, and the stimulants moderate. The alpha agonists, we still don't have a clear picture, but it's considered emerging. SSRIs, mood stabilizers, and anti-epileptics, it's considered insufficient. So we rampantly use the SSRIs despite the fact that there are really no good published clinical trials showing they're efficacious at all. However, people will talk about there's a big difference between statistical validity and clinical validity, right? Studies are based on statistics, but ASD is so heterogeneous that you can't capture all that heterogeneity a lot of times in your study population. So just as a humanitarian gesture, if you're not doing harm, you're going to end up trying these medications, and sometimes you're going to hit it right, and it's going to work. So in the hands of the right prescriber, if you're not doing harm, you're using a low dose, you're going slowly, you're titrating carefully, it can be worthwhile to try these medications, and they are tried, even though there's not great data to support them. Okay, so I'm going to go over a couple of things that are a little more marginal, but they happen to be areas of interest to me, so I wanted to share them with you. Mindfulness meditation, especially in the form of MBSR, this has good data. MBSR, not necessarily for individuals on the spectrum, but there are people looking at this work and doing it. And meditation, this is not spiritual. This is not reaching nirvana. This is not that kind of meditation. This is to reduce stress, anxiety, improve attention, focus. I encourage any of you, either parents that are listening online or that are here today, as caregivers, it can be very helpful. There are people looking at trying different MBSR techniques and protocols, particularly in high-functioning individuals on the spectrum. There are absolute changes that are measurable by fMRI and other imaging techniques in blood flow and connectivity and biochemistry in the brain with MBSR. Improved cognitive control, regulation, reduced sensory and emotional reactions. This is some good stuff. So it's certainly worth investigating if you don't know that much about it. Hippotherapy, aquatherapy, pet therapy, aromatherapy, all that stuff, it's not harmful. And so I always encourage people to try things they want to try as long as there's no harm. But you'll notice that does not include things like hyperbaric oxygen therapy and some other thing, chelation therapy, that are much more invasive, and there have been actual deaths and some evidence of harm. So I do have a line that I draw because I think you have to be careful, because someone will offer a parent with autism something. Everybody's out there offering something. So my advice is always to do your research and check with reliable sources. Not all research is the same. So when there is a journal somewhere that will publish something. So there's good portals of information to look at, the NIMH, the NIH, the CDC, and so forth. They're good resources. So research trends, the big pharmaceutical company investment in psychiatric drug research is really not there. It's declined a lot. Once Prozac came in and the other SSRIs, there's been very little new on the market. In fact, all the ADHD drugs, there's about 30 now. They're all reformulations of methylphenidate and amphetamine. It's amazing. Do you know what Cotempla is? Adzenys, Mydayis, Quilivant, any of these? These are all new. There are so many forms out there, and they're all very expensive, but they're basically different forms of Ritalin and Adderall. And that's all we have that's new. Nothing else new out there yet. So some of the things that make it challenging has to do with the complexity of doing the research, with things with patents, and the popularity of generics have made it less attractive for some of these big pharmaceutical companies to study some of these novel drugs. There certainly are private and public foundations studying the autism treatment networks through Autism Speaks, the UC Mind Center out of University of California. I mean, we have Scripps. I left them out. I should add them here. It looks like they're doing some good stuff. UC Davis, that's supposed to be, not David. Duke is doing good things, good work. However, we live in an unstable time. Did you know that? We do. And so it's hard to say where things are going to go and how funding is going to be impacted by this. There could be some unknown effects from this because certain organizations, especially on the federal level, we have always relied on the NIH and the NIMH and the CDC and the FDA for unbiased research. And I don't know how threatened some of that funding is going to be, so it's a big question mark for me. New developments, so there are, things people are always looking at. The GABA system, because GABA is involved a lot in inhibitory control as well as sensory processing. The endocannabinoid receptors, that's super hot. Every day, somebody asks me about cannabinoids and CBD oil, and I wish I had answers. I really do. I wish I did, but we don't. There isn't enough research. No doubt that's an area that is worthy of research, but just putting a kid on the spectrum on some form of cannabis is not a solution. And if any of you have any references out there you want to share, I'd love to hear it. But there really isn't a lot out there yet. But I think it's an area we're going to see things grow. The importance of the microbiome and autistic behaviors. There have been a lot of studies on mice. That's the popularity of probiotics and other things. That's a very hot area of research. Oxidative stress, of course, and free radicals in the bloodstream. That's something that's been looked at. People are still, I think Peter Mundy, who used to be at the University of Miami with their card center, he's doing some research with virtual reality and ASD, and people have looked at different apps and video games and virtual reality techniques to augment drug effects and also to deliver different social skills therapies for individuals on the spectrum. Oxytocin continues to be a hot area of research. And the cord blood Duke study, I've had 3 patients actually enrolled in that study. 2 have had very interesting, very positive outcomes. So that's an ongoing study. And of course, the work in Fragile X, which was sadly really disappointing. There were several really promising drugs, and they went nowhere. But that area of research is still of a lot of interest to individuals who are treating people with autism. Trauma therapies in ASD. I was just talking with Jack Scott about that because in the wake of the Parkland shooting, which is where I'm from, Parkland, and having to learn a lot more about trauma and trauma care and trauma therapies and the traumatized brain, I'm like, wow, there's a lot of overlap here. Individuals with ASD have a lot of overlap. And so I think that's a really interesting area. And Jack was actually aware of some of the research that I'm not, that he's going to share with me. So on that note, I want to segue to this. Indulge me for a moment. So ASD and gun violence. So this is a hot topic. So we all should think about it and certainly be informed about it because it's going to come up. In the wake right after the shooting, when the news was still flying around and things were very hot and heavy, I got together with Stacey Hoagland, who many of you may know. She's president of the ASA for the state of Florida. She had to write a statement because there was some quick, heavy backlash against individuals on the spectrum after the shooting. As a group, individuals with the ASD, the studies have shown, are no more likely to be involved with gun violence than the general population. And in fact, individuals with a disability are much more likely, 2.5 times more likely, to be the victims of a violent crime, and police are much more likely to use deadly force against them because of erratic behaviors. And there was that case in Miami, that famous case everybody knew about that was caught on video with the young man with autism and his caregiver who was shot in the street. But the truth is that Adam Lanza and Nicholas Cruz both carried autism diagnoses in their history. I'm not privy to their medical records, but they did. They both did. And we have to reconcile that. We can't say that's not there when it's there. So what do we need to do about that? Well, any of you that treat individuals on the spectrum have to have encountered teenagers on the spectrum who are obsessed with first-person shooter games. I have seen that. Obsessed with guns. I have seen that many, many times. These are a vulnerable population. So my point is that we can't close our eyes to them. We have to be vigilant with these kids and take this really seriously and be really, really careful. Like maybe it wasn't a great idea for Adam Lanza's mother to take him target shooting and introduce him to guns, which happened near the end of his life and what got him into that. That is not probably a great idea. So isolation, access to weapons, lack of social supports, these are real risk factors, and these are things we have to question families about. Fortunately, a law was overturned in the state of Florida. The NRA had sponsored legislation to make it illegal, got that, for a physician to ask a family about gun safety. Not talking anything political. Just like, is your kid in a car seat? You know, you need to strap them in, you need to wear a seatbelt, do they know how to swim? If you have a gun, it needs to be locked. And safe gun storage, there's a whole protocol for that. It was called the Docs versus Glocks bill. Does anybody know about it? You guys know about it? So it got overturned, thankfully. And so now we're allowed. But things like that are absolutely like ridiculous and an obstruction to care, we need to be mindful of. But kids who are isolated and who are their only social connection may be a first-person shooter game online. That may be their only friends. So we need to be thinking about, well, what other connections can we build for these kids? I had a kid who came into my office the day after the shooting, and I was kind of hyped up, and he was depressed and geeky and not on the spectrum, but he was like, you're perfect. He'd been bullied, he'd been isolated, he'd been homeschooled. He wasn't doing great. And I said, hey, could I look at your Instagram? Do you mind just showing it to me? it looked like Nick Cruz's Instagram account. Now, it was an airsoft gun. It wasn't a real weapon, but you couldn't tell. So I said, hey, maybe we should talk about this. Like, maybe this doesn't look so good. This is his only social outlet. That's it. And the mom said, we don't own guns in the home. Please talk to him. I know I told him you should take this down. It's scary looking. So, you know, these are things maybe we need to be thinking about a little bit more when we see our kids. You know, taking these histories and providing other social opportunities. Because this is a kid maybe who we could get him interested in another hobby. Because it's just, you have an airsoft gun and then what's next? I don't know. Maybe it just stays at airsoft, but that's it. That's all he's got. So that's it. That's all I have today, you guys. You're so quiet. Anybody have other comments or questions or things they want to raise? Everybody wants to go to their Seder or Good Friday stuff. Well, I mean, a lot of times the way they present to me is they're depressed. They're clearly depressed. They are shut. I mean, you know, depression, I guess, is the primary way. Sometimes they present also with anxiety. Some present with externalizing behaviors. So they're angry and they're acting out and they almost look more like a conduct disorder and there's misbehavior. Lack of parental control, defiance. I mean, there's a lot of different ways they can present. Sometimes, you know, they're being dragged in by a family member. They're like, I'm fine, get out of my face, leave me alone. Like, I don't want to be here. I'm fine the way I am. I'm okay, leave me alone. But it's not really a sustainable life to be just playing video games 8 hours a day, you know. So that's commonly what happens. That's commonly how they present. Yes? Mm-hmm. Mm-hmm. Okay. Yeah. Mm-hmm. Mm-hmm. Right. I mean, I think there's actually, I mean, I don't treat adults, so I just treat the pediatric population, but it's very interesting because I do sometimes get other family members get diagnosed as the kids get diagnosed. So the typical profile is a dad who's in IT. I'll say, you're in IT, right, or software engineering. They're like, how did you know? Not to stereotype people, but that's just a common presentation. So I think there's a lot more out there, especially when it comes to this concept of transitioning, because I have an older, my older daughter, who's 24, is on the spectrum. And when she was diagnosed, this is 22 years ago, there still wasn't as much awareness as there is now. So following her progress, and she's getting mentored, for example, in her job, there's a lot more out there. I mean, certainly there needs to be more. The thrust tends to be on early intervention in younger kids, but I think there's employment initiatives. There's more companies. There was a big, actually, profile. It was either on 60 Minutes or one of the shows where Microsoft has a huge initiative where they're actually looking for individuals on the spectrum to hire, and they're finding they make great employees. They provide them with a lot of training and supports. So there are other, I know CARD has sponsored some other events and speakers who are working more in this area. But I wanted to say one thing about the gaming. Don't get me wrong, I'm not saying take all gaming away. There's actually a guy, a parent, who created a special server. It's called AutMind, I think, A-U-T Mind, for kids who play Minecraft, who are on the autism spectrum, or if you just Google autism spectrum Minecraft dad, he gave a TED talk, and he created this kind of he proctors it. So there's no bullying going on, and kids are being pro-social. So gaming and screens and servers and playing online, these are ways people connect, and they can be super positive. They can be really good, and sometimes they're the only social connections for people. So it's not about entirely taking those things away. It's about monitoring and guiding and directing it appropriately so that people are not dissociating and thinking they're living in a first-person shooter game, and that's their only social outlet, The American Academy of Pediatrics has several initiatives where they're trying to help general pediatricians educate families on screen time and screen use, because it starts with the adults, right? So when the parent comes in to my office and they're like, I'm like, I hate to interrupt you. I mean, they're on their phone the whole time. That kind of behavior is problematic when they're raising their kids and they're on screens all the time. So giving families strategies and screen-free dinners, screen-free meals, screen-free nights. There's a campaign called Screenagers, some of you may be familiar with, that has some good information and activities and ways parents can encourage their kids to get off screens. But screens aren't going away, and screens are lifesavers for some people, but it's just, once again, sort of paying attention to what people are doing and making sure they're not spending all their time doing things that may not be so social.
Is there anything that you've researched or read about that can explain the rise of anxiety that we're seeing with the general population as well as ASD?
That's a great question. I can't point specifically to any one study, except people have written a lot about we're living in an anxious time. So even just look at gun violence, not to obsess on it, but to go back to that. That's the third leading cause of death in the pediatric age group. And so there's also, some of you may be familiar with ACEs, Adverse Childhood Experiences, the ACEs study, which are sort of these 10 pivotal events that if somebody is got, I think, 4 or more, your lifetime risk for serious medical issues goes up astronomically. But I think that, anxiety as a worldwide problem, it ranks 9th, that I know for a fact, by the World Health Organization. So globally, it's a serious issue, anxiety, on a global scale. I mean, I think we have a lot of explanations for it with, erosion of the family, financial pressures, social pressures, gun violence, screens. I mean, kids who look on Facebook all the time and they think, wow, that's the way I'm supposed to be, and they measure themselves up to some unrealistic standard of what life should be like for them. All of these things can promote anxiety as well as depression. But I don't have a specific study to cite, but you're correct. The baseline for anxiety has gone up, just as a society. And now, that said, we still have some really effective and good treatments for it. Oh, you had a question? I'm sorry. Mm-hmm. Yes, yes. And in fact, so I could make a medical diagnosis that's valid and legitimate, and I'll write a letter, and the family will go to school, and they'll go, that's really nice, but sorry, we're going to put them through RTI, and if it's not educationally impacting, they don't get services anyways, so there has to be some educational impact for them to qualify. But virtue, the days of just a medical diagnosis, it's not helpful, no. I mean, a medical diagnosis doesn't necessarily jumpstart the process. Yep, you're 100% right. And then what's the time frame? Is it 60 days? Business, business days. It's an important distinction, yeah. I mean, I see schools out of compliance like constantly, and parents are told some crazy stuff. And it's not to diss the educators. They are completely overworked and overrun. But I've, you know. Mm. Mm-hmm. Yeah, I would agree. I see that as well. I do see that too. And I see kids really being hurt by it. And Child Find, you know, and the early intervention programs as well. It's problematic, you know. And until we change priorities with funding, I don't see how this is going to change, you know. So it's tied to money to a degree. Now, I always empower parents. A parent could come in and they could have no insurance, they could have nothing, and I'm like, all right, we're still going to have a plan. You're going to read the Early Start Denver Model Parent Handbook, and that's what you're going to do at home. And then you're going to find a grad student who wants to practice on your kid, and that's how you're going to get your ABA. And we work with whatever they have. You know, you have to be practical. If you create a treatment plan that a parent cannot follow, all you do is traumatize that parent because they think they're being terrible parents. And I've had people wait 6 months to get an ABA provider. And you can't wait 6 months. So I'm like, you're going to get on the floor and do things. Like you're going to, and some of these, there are some online trainings and, you know, I mean, there are things that people can do and you have to empower them that they can do that. The last thing they need to hear is, I've just failed my child once again, you know. So, and there's, you know, the CARD Center also. I mean, I send them to CARD all the time. Everybody, any new diagnosis of a child on the spectrum or a teenager in my office, that's one of the top 3 things they get. They get a brochure and a script for CARD Center services just to empower them and educate. Yeah, there's some good stuff out there. I actually use CogMed. You familiar with that one? Yeah, it's a working memory deficit training program, rigorously studied, great evidence. That's the one I happen to offer and I happen to like. There's others out there. I mean, Fast Forward is more for reading. But I think it's certainly valid to include that in your armamentarium of things to do. Absolutely. Thanks for bringing that up. There's some good therapeutic stuff out there. CogMed, COGMED. You can look it up online. They have a very active website. But the initial study for CogMed was a double-blind, placebo-controlled study where they did functional MRIs of the control group and the treatment group and showed significant improvements. And there are others out there too. And there, you know, people know Lumosity and some other programs that are more geared for adults. But I think it's certainly something else when you look at trying sort of a multidisciplinary and different modalities. It's a good one, especially for attention and working memory. There are some social skills training programs as well. I can't cite you particular ones, but there's really good delivery models because everybody's got a computer in their home, you know, and there are online ABA training modules. I think it's Rethink Autism. They visited CARD years ago, is when I first saw them, and you enter data about your kid, and they come up with a lesson plan, and then they model, they show you the, you know, ABA lesson, and then the parent does it. So there's some good stuff out there, and we really do need to be looking at different delivery models because the idea of an insurance provider paying $40,000 a year for 40 hours a week of one-on-one ABA therapy, I just don't think it's sustainable. So there's going to be new ways we need to think about delivering even therapy. I think that model is, you know, needs to be looked at. Maybe small groups, training the trainers, training other people, because it's a very expensive model, which is why insurance companies are fighting. I mean, they're fighting hard. And some are plan exclusions, you know, that I don't know what year the legislation was passed, but there was some federal legislation passed that if you have more than, I think it's 100 or 150 employees, autism coverage is mandated. But I think that's going to get eroded away, and then it's going to be a free-for-all. Yeah, yeah. I mean, music therapy I'd put in that same boat with hippo and aqua and some of those other therapies. And some kids are super responsive to music, which I think is wonderful. And it's a great avenue to reach some kids. Craniosacral doesn't meet the rigor of evidence-based research. It might help somebody, though. It doesn't mean it couldn't help them. It gets, once again, into that basket of do you have the resources and do you have the time? What concerns me about therapies like craniosacral and the Muscatova method are the claims they make. So they make sweeping claims about their ability to affect therapeutic change and cure, and that bothers me because, you know, there's no data to support that. I think that's it. Everybody wants to go home. Beat rush hour. All right, well, thank you. Yes, one more? Yes, please. Mm-hmm. 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 Non-psychotic schizophrenia, you're saying. There are things that differentiate the two, you know. So, I mean, certainly sometimes, to Mary Ellen's point earlier, we misclassify, and we may think it looks like ASD when it's not. I mean, there are some rigors, so there is that ADOS that I mentioned. So there are, in a case where it's really unclear, and it's very important to know, there are certain diagnostic assessments that could be administered that really should help you to differentiate. But there are certainly, I mean, there are plenty of individuals, for example, that have been misdiagnosed with schizophrenia that in fact have autism, especially years ago. There's a great movie, Wretches and Jabberers. Do any of you know that movie? It's a beautiful movie. It's a documentary about two men in their 50s who both were in psychiatric hospitals for the majority of their lives, and they really were missed ASD cases. It's a wonderful movie. I think it's on Netflix. But yes, so that's where a team approach comes in. So, you know, if a psychiatrist says it's schizophrenia and you think, I'm not 100% sure, get a second opinion. And certainly get neuropsychological testing because there's more testing that can be done. Now, they could overlap, too. Not commonly, but, you know, and ASD with psychosis can be very tricky. I've had some kids that were on the spectrum that became psychotic, and then you're not sure what you're looking at, you know. And listen, kids, human beings don't read the textbooks, you know. They're not neat, and sometimes things overlap, and sometimes things aren't clear. Sometimes things are really, really muddy, and that's when just a good team, so providing the right types of therapies and the right kinds of medications are more important than pinning down the diagnosis. But yeah, it can get thorny and confusing. Anything else? We're good? Okay. Thank you, everybody. gotta do the foundation first, you know, so.
Okay. That's where I feel like at a loss. I left there not knowing where to start. You know, like, okay, check her in and then leave her.